Another aspect is that 30% of the sleep apnea population have what's called high loop gain. And high loop gain implies that this patient has unstable breathing during sleep. Going down a little bit deeper, it's that they have an increased chemosensitivity to carbon dioxide. So why would that be an issue? Carbon dioxide is the primary driver to breathe. It's not oxygen. Every breath that you are taking right now is driven by carbon dioxide. And during sleep, if that person stops breathing during sleep, while oxygen can't get into the body, carbon dioxide can't leave the body. So carbon dioxide then will naturally accumulate in the lungs and also accumulate in the blood. As carbon dioxide builds up, at some point, the individual will resume breathing. But the question to ask is, how do they resume breathing based on the accumulation of the carbon dioxide? If they're overly sensitive to the accumulation of the gas, when they resume breathing with such exaggerated ventilation, and now they are breathing so hard and so fast that they blow off so much carbon dioxide. So in other words, during the stopping of the breath, carbon dioxide was increasing because it can't get out of the body. But when they resume breathing, they're going from too high of carbon dioxide to too low of carbon dioxide because of the exaggerated ventilation to minimal increases of carbon dioxide. When carbon dioxide goes too low, the brain doesn't send a signal to breathe because bear in mind, carbon dioxide is the primary driver to breathe. So if carbon dioxide is low, the signaling from the brain to the breathing muscles is reduced, and now this can initiate another apnea, such as a central apnea. And here's the interesting point. And here's another aspect to it. When the drive to breathe is reduced, the output from the brain to the upper airway dilator muscles is also reduced. So for people who are not responding so well to mandibular advancement device, it's very important to test whether they have got high loop gain. And high loop gain can be assessed by the person's breath hold time. So if you're a dentist and you have your patient with sleep apnea, as the patient sits in the chair, check in on how they breathe and just observe how fast are they breathing. Where are they breathing to? Are they breathing open mouth? Is there a natural pause at the end of exhale? Do they have a nice, slow, relaxed exhale, or do they have a fairly fast exhalation? And that will give you a clue as to their drive to breathe. Then ask the patient to hold their breath using the controlled pause measurement from the Buteyko technique. The instruction is as follows. Take a normal breath in and out through your nose and hold your breath, and time how long can you hold your breath for until you feel the first involuntary movement of the diaphragm or the first definite desire to breathe. But the main thing is, when your patient resumes breathing, that they resume breathing with normal ventilation, that they don't have catch-up breaths. If they do have catch-up breaths, you know that they've pushed it too far. Ideally, your patient's ability to hold their breath is for 20 seconds and still have normal breathing when they resume breathing. Now, 20 seconds is really what we're looking at in terms of a minimum. 25 seconds would imply, once they're above 25 seconds, it implies that they have functional breathing. And of course, with the Buteyko method, the goal would be to reach 40 seconds. Now, of course, that can be quite a bar for people to achieve. Of course, that can be quite a high bar for some people to achieve. But even if you notice that your patient has a controlled pause of 10, 11, 12, 13, 14, 15, or 16 seconds, that patient is a candidate for high loop gain. And that patient is a candidate to have their breathing patterns addressed to reduce the chemosensitivity to carbon dioxide, as evident by having a higher controlled pause. So you have your patient with mandibular advancement device, but also breathing training and breathing re-education to restore nasal breathing with correct tongue resting posture.